Okay, so I welcome all of you for today's special topic, an expected question for an upcoming AnySet November 2021, or it could be NEET or next 2022. The question reads, a patient presented with vomiting and features of gastric outlet obstruction. He has an infiltrating cancer from the stomach to the pancreas into the duodenum and having multiple liver metastasis in the right lobe of the liver. What is the ideal treatment for him? See, this question is a CA stomach with a metastatic disease. Option A, what is the answer? What will you do for him? What's the treatment, ideal treatment for him? Palliative gastrojejunostomy, right hepatectomy with radical gastrectomy, Whipple's procedure, and palliative care. See, the right answer is only palliation. And what kind of palliation you need to do is the discussion here. The right answer is option A. Next, it is palliative gastrojejunostomy. Understand this. For CA stomach, the best form of palliation is a surgical palliation. In case the patient is fit and in case he can be amenable for a surgery, then definitely you will do a posterior gastrojejunostomy for a benign disease. But for a CA stomach, for a malignant disease like this, you will try to do a anterior gastrojejunostomy for the reason that all the cancers have a tendency, especially the gastric cancer, have a tendency to grow posteriorly, infiltration, the posterior wall of the stomach, and it goes posterior into the stomach bed. There is a gastric bed of the lesser sac, and it infiltrates to the underlying structures like pancreas, as given in this question, and the duodenum, so that this infiltrating cancer stomach involving the pancreas and the duodenum. So if you do a posterior gastrojejunostomy, as in case of a peptic ulcer disease presenting with a gastric outlet obstruction, here if you do that, there will be an early obstruction will happen, so that you will always try to do a anterior gastrojejunostomy. Understand that, anterior gastrojejunostomy, palliative anterior GJ, anterior gastrojejunostomy. Now, what are the other form of palliation? If the patient is not fit enough, you will try to do stenting. You can do a stenting across the tumor. You can dilate the tumor. You can stent it across. But the stenting for gastric cancer does not yield a result that stenting for esophageal cancer gives. The chances of the stent getting obstructed by the food bolus or the chances of the stent getting migrated and displaced are very, very common than esophageal stenting. So, if the patient is fit enough, the best will be to do a anterior gastrojejunostomy. The right hepatectomy with radical gastrectomy is not an option here. Whipple's procedure definitely not an option here. Whipple's procedure is a pancreatic duodenectomy. Is an ideal procedure done for CA head of pancreas or periampullary carcinoma of the duodenum, and it can also be a part of a treatment protocol in case grade 5 pancreatic head injury. So the best option available here, the best will be palliative gastrojejunostomy. Understood? Now, I want to tell you, you need to understand this very, very clearly, that what are the external markers of inoperability of CA stomach? Yes, inoperability, here it means incurable, not a curative resection. Correct? Where you will not do a curative resection of CA stomach. Number one, we'll go from head to foot. Number one will be jaundice. That means it tells you hepatic metastasis. Number two will be Virchow's lymph node. Enlargement of left supraclavicular lymph node. It is called Virchow's lymph node. And it is a sign of curative resection and contraindication to do a curative resection and a sign of inoperability for a curative resection. Then will be lymph node of iris. Lymph node of iris is located usually in the axilla. An iris lymph node is a metastatic lymph node of a CA stomach. And that could be a cause and that could be a reason of inoperability or a curative resection in CA stomach. Then it could be Sister Mary Joseph nodule. These are the periumbilical metastatic nodules. In a case of a CA stomach, the malignant cells follow the lymphatics of the falciform ligament to reach the umbilicus and presents as a periumbilical nodule. Clear? So that is a sign of inoperability, Sister Mary Joseph nodule. Then peritoneal involvement and peritoneal metastasis can lead to malignant ascites, and malignant ascites is a sign of inoperability and not for a curative resection. And then it could be a Krukenberg tumor. It's a transcoelomic spread of CA stomach into the ovary, into the active ovarian follicles to produce as an ovarian tumor is called Krukenberg tumor, is a sign of inoperability. And the metastasis into the Bloomer shelf, the metastasis, CA stomach getting, and a patient with a distant lymph node, distant, especially N3 and N4 lymph node, is a sign of inoperability. You understand what I say? So these are the signs of inoperability, means that this cancer is not a curable cancer by surgery. In case you do a surgery, if the patient is fit enough, you can do a palliative surgery like an anterior gastrojejunostomy. And these are the signs. I'll just repeat it once again for you for the benefit of all. So it could be the icterus, that is, jaundice, number 1. Number 2, it could be the Virchow's lymph node. Yes. Number 3 will be Irish lymph node, metastatic lymph node in the axilla, most commonly on the left axilla. Number 4, Sister Mary Joseph nodule. Number 5, ascites. Number 6, Krukenberg tumor. Number 7, Bloomer shelf metastasis. Number 8 could be distant lymph node metastasis. Number 9, any distant organ metastasis in the CA stomach is a sign of inoperability and is a contraindication for curative resection. Understood? Is it very clear? Now go to the next slide. Now, where is the substantiating point? The 21st edition of Subiston is the latest edition of Subiston. And because, see, as an undergraduate during a final year, to you to read Bailey itself is a very big deal, and to read on to Subiston textbook and to read on to Schwartz textbook of surgery of 11th edition will be a big task, but the questions are asked from these books. So it is the responsibility of teachers and faculties like me to read those points and get on to you the crisp of the gist of what is given there, so that you will be able to answer it in the exam very easily with the reference. So it is very, very clearly given in page number 1213, 21st edition of Subiston latest edition. It came 6 months before. Now it very clearly explains the patient with unresectable or metastatic gastric cancer account for almost 50% of patients presenting with the disease have only 3 to 5 months of median survival with the best supportive therapy. While many patients with advanced disease are asymptomatic, a significant subset of patients with an unresectable gastric cancer have debilitated symptoms and should be considered for palliative surgical therapy even in the setting of metastatic disease. So metastasis is not a contraindication to a palliative surgery. Be contraindication for a curative surgery, but not for a contraindication for a palliative surgery. The most common procedure in the setting is gastrojejunostomy. I said it is an anterior gastrojejunostomy. However, a palliative gastrectomy can be considered in a select patients. Understood? So it is very, very clearly said. And go back to the question. And this is the topic for us to discuss today. CA stomach, one of the most common cancer in GIT. Yes, in GIT, they'll ask you the other questions here. It is the most common location of lymphoma in GI. The most common location of lymphoma in GI is stomach. They'll also ask you the most common location of leiomyoma in GIT. Again, it is stomach. So anything they ask you in GIT, the most common site is, one of the most common site is stomach. So you need to understand that. Okay. So CA stomach is a very, very, very important topic in exam, and management of CA stomach is also very important topic in exam. So we will be discussing all this in detail in the classes, and this is expected question for the upcoming INICET and the upcoming NEET exam. So an elaborate class will discuss end-to-end and everything on all these topics. So I request all of you to come to speed, join speed, and also you will learn a lot, and definitely you will enjoy learning, and you will definitely have a difference in learning, and you will love it. And Speed Learning app is such a wonderful tool, and it will give you live classes and very good classes by the faculties. And I once again welcome you to join the Speed Learning app done by Speed Institute. Thank you very much and have a wonderful day.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.